Health is defined as physical, social, and mental well being, and not only the absence of disease or infirmity. 1948, World Health Organization. We have all learned that, and we continue to say that. Is that what we give when somebody comes to the hospital? Physical, social, and mental well being? You and I have been trained to look at the body minutely, including the individual cells. Look at the chemistry, look at the physiology, study the pharmacology, and all that. A very famous person, doctor by name Eric Cassell, said, "It is persons that suffer, not bodies." Nobody taught us to look at persons. In fact, in words and more in practice, we were told, don't allow your emotions to interfere with your work. In essence, saying, be a good mechanic for a body. Don't, emotions, compassion, not permitted. True, it's difficult to survive unless there is a way of surviving even after recognizing suffering. The duty of care of a healthcare provider is officially defined by the bioethics unit of Indian Council of Medical Research. The duty of care of a healthcare provider is to mitigate suffering. First sentence, mitigate suffering. Do we know how? Even basic pain relief reaches less than 4% of the needy Indians, leave alone other aspects of well-being. It is to, the definition continues, it is to cure sometimes, relieve often, and to comfort always. And it adds, there exists no exception to this rule. There exists no exception to the rule that you and I have a duty to mitigate suffering. Not only we do not mitigate suffering, we add to suffering. Oh, by curing, by addressing diseases, certainly we mitigate suffering. But remember, only 1/3 of diseases can be cured. Maybe another third can be controlled. Diabetes, hypertension. How many get actually controlled? If you consider the low and middle income group, well, leave alone that failure to mitigate suffering, we add to suffering at least in two contexts. By data from 2015, reported in 2018 in the British Medical Journal by Shaktivel Selvaraj and colleagues, every year 55 million Indians are pushed below poverty line by catastrophic health expenditure. India is among the worst 12 countries according to World Bank data in the matter of catastrophic health expenditure. 55 million works out more than 4% of the population. Healthcare providers, we are destroying the social and mental and physical health of more than 4% of the population in a year. Oh, it's better to pretend that it doesn't exist. We add to suffering in another horrendous way. This is very Indian. And this happened in the last 25 years. The concept, which is now accepted by the person on the street, that one's final days had best be spent in an ICU, where you will be shivering constantly because of a temperature of 18 degrees centigrade. And every day, if you are still conscious, aware that your children will drop out of school, where there will be one tube in every orifice in the body, where I'm an intensivist by training. I know that intensive care can miraculously save lives. But I also know that in that context, in the context of incurable illness, it is the worst infliction of suffering on the human body and mind and spirit. When my term comes, if I end up there and I try to pull out the tubes, my hand and feet will be tied. This is also Indian. In Euro-American countries, if restraint is necessary, it is chemical. There are sedation protocols. In our country, this is the routine. What a way to die. What would be most important for me in the last few days of my life? Any of those tubes? Any of those machines? Or will it be a kiss from the grandchild on the cheek? Do you know of any intensive care unit where a child is allowed in? These are some of the realities which it's easy not to talk about or think about. We talk about healthy aging. We say not very meaningful things like age is but a number. We don't think about the people at the end of life. I'll be talking more about them. Lancet Commission on Access to Pain Relief and Palliative Care in 2017 published this paper, which focused on health-related suffering as the focus of healthcare. Serious health-related suffering. And that was such a huge shift from the traditional concentration on diseases that it is talked about a lot now. And I am talking about palliative care. Palliative care is not only for the elderly, of course, not only for cancer, not only for the end of life, it's for management of all serious health-related suffering across the continuum of the disease, continuum of the illness, from the beginning of the illness, from the beginning of the suffering to the end. And this is for the patient and family. The family, the unseen martyrs who are never recognized. Imagine the life of the spouse of a person living with dementia. How many years? What kind of life? Do they get any attention? Does our patient record have a column for that caregiver's health? Maybe some do. Maybe that's necessary everywhere. The suffering can be in all these domains. Physical, social, mental and spiritual. I am not going to the details, but you can imagine the anxiety, depression, guilt, everything, and the social issues including poverty, but also relationship issues, abandonment of women, abandonment of children. All these things happen. And spiritual, I don't only mean things related to God Almighty and religion and faith. It's also about meaning of life. When somebody every moment is thinking, what's the point of living like this? I wish I could die. That is spiritual agony. When somebody is totally disconnected from his or her world, like in the ICU, or when with all love for your parent, you shift them from the village and take them to live with you in a 30th floor apartment in a busy city, you have lost his or her world. The elderly get disoriented. 2/3 of them get disoriented within 48 hours of an intensive care unit. Data. All this need to be addressed. And that's palliative care, which according to the World Health Assembly, which is the decision-making body of World Health Organization, integrate palliative care into all healthcare. Let us not think about healthy aging only up to the point of being ambulant, but also about to the last moment and beyond that for the family. Integrate it into all healthcare. It's not for a few crazy palliative care physicians and nurses. It's for every single clinician. Everybody involved with healthcare. It's also for the community. at all levels, primary, secondary and tertiary, because if your tertiary institutions do not do it, it will not percolate down across the continuum of care from the beginning and the suffering to the end. Even in palliative care organizations, I know there are several here, very often, including we end up doing only the surface work, the symptoms which are very visible. We need enough time. If we can go there, we then find the real huge issues related to emotional, social issues, poverty, the relationship issues between spouses and the rest of the family members, and the spiritual issues and sexuality issues which are at the deepest. That needs a little training. Is this likely to happen? It's happening. Palliative care is already in the National Health Policy of 2017. It's already in the MBBS curriculum for 2019 and in the nursing curriculum since 2022. There is an implementation gap, but it's for us to fill that. And now if we are to do that adequately, we have to engage with the community. I know there are many public health people, and maybe me lecturing to them is a bit audacious, but I will still remember that it is 1978, 47 years back, we all met together, including India, and decided that the people have a duty and a right to participate individually and collectively in the planning and implementation of their healthcare. In the next 40 years, nothing at all happened globally, and they met together again at Astana and came out with this declaration, reiterating much of what Alma-Ata declaration said, but clearly adding that care has to reach people where they need it. Many people here make it happen. Vasundhara, Shujit, you are all making it happen. Care reaching people where they are, when they need. When they need it, maybe quite a lot of way to travel, but at least at times reaching people where they are in their homes is so essential, because we find that the most needy never reach hospitals. If that is to happen, healthcare for all, to quote them, is healthcare with all. Engage the community, involve people in designing and controlling health systems, because you all know that health needs not only the Department of Health and hospitals, it involves food, agriculture, irrigation, sanitation, transport, which government will collate all that and do it. But the local community will, like we was showing Pankaj Kasturi and Dr. Pankaj Kasturi and others, there was a man living in this hut with advanced malignancy, elderly man, sitting and holding an umbrella inside his house because his house was leaking. What would your healthcare system do for that? Our medical social worker got together a few young people in the community and they pulled that tarpaulin sheet. The man could lie down. Those 5 people did something about 100 times more important than what I did by prescribing those medicines. Engage the community and they will find solutions. The team members should include family caregivers, because we have data that from one study which showed that about 72% of all healthcare was given by the family. We need to nurture that. Volunteers from the community have a huge role to play, and of course professionals, certainly of all nature, have to come in. Anybody who can improve the quality of life of the patient and the family. And this can work, as I said, only if we integrate healthcare into all healthcare. The top triangle is for a few palliative care units, but every healthcare professional has to integrate these principles into their healthcare, which your juniors in medical college and nursing colleges are going to learn now. But at the foundation of it all is the community. We have to engage with the community, and as the Maori proverb says, what's the most important thing in the world? It's the people whom we try to keep out of the healthcare system with armed guards. And reaching out into the community is essential. We are very comfortable in our air-conditioned hospitals, but we are not reaching the most needy. Even among the elderly, there comes a time when the elderly are in the home and they refuse to come to the hospitals. And getting down to their level, learning to sit down and listen to them and give them care, that has to happen. And like that doctor and that nurse, doing that and practicing it and making that visible to nursing students and medical students is vitally important. And the community, that was community outreach. When we say community based, that involves engagement of the community in the actual decision making process also. They know the local issues, they will find the local solutions. That woman, the gentleman standing in the rear is a local volunteer who set up a local palliative care program. That's one of about 350 in Kerala. And this woman had a knee replacement surgery and would have never walked. But this man enrolled his school student next door to come every day and to make her walk. And the doctor reached them and they together made sure that they could walk again. Because if not, the surgery was only infliction of suffering. Of course, the volunteers have to be trained. They have to accept the core values, like patient and family being at the center. The very clear message that what we are doing them is not a charity. We are just choosing to give them their right. Because there is a lot of difference in throwing them something like this and giving it with respect. And there has to be the balance between compassion and competence. Because we are going there and sometimes often doing it free, it doesn't mean that anything can be done. Competence is vitally important. And I have to remember that every one of you, I don't know you, every one of you has something that I do not have. Maybe you can dance, maybe you can sing, and most of you I know are mentally stronger than I. And therefore, I treat you with respect. And respect is often contagious, just as a smile is. And the volunteers also have to accept the ethical practices. So that means training becomes necessary. Very often there are legal and procedural barriers, especially in Western countries, much less here. But the major thing is that we are keeping the healthcare system locked without allowing volunteers to come in. And healthcare professionals generally resist participation in the community. We are afraid. We are also angry often because they will come and argue with us. Of course they will. We have treated them with respect and acknowledged their value. They will argue with us. And that is healthy if we accept it. But if we are to happen this, the series have to be like this. First, within the team, we have to accept that the community volunteers are essential. We are ready to welcome them. This is the hardest, I think. We do awareness programs wherever people are willing to listen. We work with the television, radio, everywhere. And at the awareness programs, usually if I address an audience like this, some 20 people will raise their hands willing to be volunteers. If 20 people raise their hands, at the actual meeting, 10 people will appear, 5 people will start volunteering, and at least 2 will stay back eventually. The training program, we have more teaching modules and handouts to give. Everybody accepts the core values and ground rules, including respect. And the program is launched at all levels, including the highest level. Say in Kerala, the government of Kerala has a palliative care policy, which happened because of the NGO activities becoming so popular. The government does what is very popular. And at the high level, at the level of the hospitals, and at the micro level, at the level of the patient. Because unless it is accepted at the top, it's very difficult to work at the bottom. And we need to do an evaluation periodically. As we were in chatting outside, Vasundhara was telling me she does rural community work in healthcare. Vasundhara told me about that much too often in the villages, an elderly person's death is noticed because the stench coming out of the door on the third day. It's happening now more in the cities and apartment buildings. The community is fractured and we don't know what happens there. So the course correction has to happen where we are going wrong. As I said, the closeness of the healthcare system is the biggest barrier, but also problems that can be expected are volunteers are also human beings. They may have personal agendas. Political and religious agenda, vested interests are much more dangerous, including fanaticism. That's why core values need to be defined. I don't inflict my values on anybody. We understand their values and respect that. I will stop there with the presentation and I look forward to the discussion that will follow. Is that happening now or after the next talk? Thank you very much for listening to me so patiently.